Dear Pure Urology viewers, good evening, one and all. After a little bit of time, we are having a session again today. We have taken a pause a bit in the last 2 weeks because of a lot of conferences. Welcome once again. Again, today we are discussing about the flexible ureteroscopy various baskets by Dr. Parimal Gharia. He already has done once the program in our group. So I will briefly introduce again, and then without wasting time, we will go to the topic. Various types of baskets in flexible ureteroscopy in detail is very important. This he presented in one of the conferences in our country, and I heard, and it is very valuable. And then I requested him to do that. Dr. Parimal Gharia recently has shown a lot of interest in flexible ureteroscopy related aspects, particularly the suction through the access sheath. He made his own innovative thoughts and applied it for the suction through the access sheath by manual aspiration, which is least cost and most cost effective. He is consultant urologist practicing at Icon Hospital, Surat. Endourology and laparoscopic urological surgeries are his areas of interest. He is proponent of suction in RIRS, as I said, for which he has developed a simple and cost-effective way of using 10 centimeter and 100 centimeter extension with three-way and suction ureteral access sheath. This definitely will pick up in the future because most of us are doing RIRS, and if you take out the dust, we will feel happy that we have finished the case perfectly. Only thing is, it needs some expertise. Recently, I heard that only floating part can be aspirated. You should not aspirate the stones on the surface of the this thing, otherwise it will suck the mucosa, bleeding can occur. We are also in the learning phase, but definitely the lot of people are doing dust now because of advanced technology in laser, and that dust, if it is removed, it is better. So this is interested. Is actively participating in academic activity at journal and the national level. Have strong social media presence, especially Twitter. He posts, discusses, counteracts, acts. That helps to learn the science for all good. So thank you, Parimal, for joining. And once again, welcome to Pure Urology. I hope this talk will be very useful for the youngsters because baskets will stay. Even though it is some people use less, will stay, are needed in some cases. In fact, in children, when I do everything, I need at least last I have to take sample. Without basket, you cannot take sample. In pediatric age group, sampling the stone is very important. So today, Parimal will deliver all about basket so that it will be a landmark YouTube link where you can refer as of today. Thank you, Parimal. Over to you, please.
Thank you, sir. Thank you, sir, for inviting me for a pure urology talk again. I will will share my screen.
Okay. Okay. It is shared.
Okay.
Yeah. Right. Please go ahead.
Okay. So I declare no conflict of interest. I am not associated with any company that makes baskets. I will be focusing more on upon the available baskets which are available in India. And I would to declare that some of the videos in this presentation has been downloaded from Twitter X from the permission of Dr. Said bin Hamri with due acknowledgement. The first description of basket started in 1961 with the Dormia was introduced first in the market for the ureteroscopic retrieval of the stones. And from that generation, we have come to long, and we have plenty of baskets types, and different type of baskets are available in the market now. So we need to learn about which basket for which use. So actually the overall classify, or you can say that the type of baskets can be classified according to the wire material, like the stainless steel versus nitrile. According to the shape of wire, there are three types of shape: flat wire, round wire, and delta wires. According to the arrangement of the wire, like a straight wire or a helical wire, and according to the action or the opening action, side action or a front action. Number of wires, according to the tip design, there are either a tip or a tipless baskets, and the geometry of the cage, how the cage looks on the geometry, how it's a walnut shape or a teardrop shape, etc. So we'll discuss about the material first. The original baskets which were in the market were the stainless steel baskets. The stainless steel basket does not have any shape memory. So once the the shape of that basket is deformed, it is permanently deformed, and it doesn't recognize the shape again. So it becomes odd to use that stainless steel basket. Then comes a material that is called nitinol, which is called nickel titanium alloy, and which is the 50-50% material in that. The most advantage of nitinol is that it is a kink resistant material. You can see that it has a shape memory. So whenever a nitinol wire is deformed and again it is heated to the temperature, it will again take that shape. That is this memory. This is called shape memory. This is very important in the basket to have a shape memory, because we retrieve the basket inside the seat, and whenever we deploy the basket, it has to take a typical shape for that. You can see that the second characteristic of this nitinol wire is it's a super elasticity. If you stretch the basket, it will deform, but again it will take a same shape. So the super elasticity and the shape memory are the two important points which drives the nitinol market, nitinol baskets wires into the basket business. So next is a round wire baskets. Now we'll talk about the wire shape. This is called round wire basket. There is a sheath around this, and this sheath has 4 wires. All the 4 wires are the round wire baskets. So you can see there are a lot of space is wasted around these baskets, and it is a round wire baskets. Next is a flat wire baskets. The next generation of the basket which come into the market were the flat wire, where the outer surface was round and the inner surface was a flat. Look at this Segura basket from the Boston. This is a flat wire basket. The inner side is a flat, but at a disadvantage, this is a sharp margins. This sharp margin can be damaging to the mucosa. And then Cook came with a significant improvement in the wire technology. They made a delta wire technology. The wire are shaped like a delta or a D. So you can see that the lot of mass can be in a same sheet diameter. If you are taking a 1.9 French diameter sheet with a round wire baskets, it will have the thinner baskets, thinner wires. Whereas if you are taking a delta, the wires are thick and it's more resistant to kink or a breakage. So the large wire mass can be included in a small sheet, and this will allow more radial force for basket, so the greater dilatation of ureter can occur. Then the classification comes is the number of wires. You can see that this basket is a 3-wire basket, this is 4 wire, this is 6 wires. Then the tip or a cage design. When the wire are deployed straight, it is called straight design, or when it is their helical shape. Their helical shapes are made to retrieve the stone from the ureter. From a straight wire, it is very difficult to engage the stone in the ureter and then to retrieve. So they came with the helical design of the basket, so that the helical design can be rotated and you can find the you can grab the stone and remove it. This is the Segura typical tip deep basket, Segura basket. You can see there is a tip and there are 4 wire baskets. This is the N-Force from the Cook. It is 3-wire technology, but it is a tip. Now the earlier generation, the goal of retrieval of the stone was only from the ureter. So you required a tip basket which goes pass through besides the stone, go up, it is open, and then it is retrieved. The stone is grasped and the stone is removed. So the initial tip design was more focused on the ureteroscopic stone removal, or a semi-rigid that is used in a semi-rigid ureteroscopy. But as the flexible ureteroscopy use advances, we need to remove the stones from the calyx. The calyx is, so the pointed tip is damaging into the mucosa. This touch the mucosa, then the mucosa bleeds, and it is very difficult to grasp the stone from the calyx in a tip basket compared to a tipless basket. So that over a period of time, the tipless baskets comes into the picture. You can see in this study by Honey that the tipless baskets were way faster to grasp the stone compared to a flat wire tip baskets. And secondly, the flat wire baskets, which are tip basket, require 12 mm protrusion further than the T-place basket. So it is in a narrow space of the calyx, it is very difficult to grasp the stone with the tip basket compared to a T-place basket. So the T-place baskets come into the mainstay. Second is the body of the grasper. The body of the grasper is a sheath. It is a sheath with a coating. That coating is a hydrophilic coating, and so the sheath it's covered with a protecting cover. So the wire inside moves, but the sheath remains same. Then there are different type of baskets with the handles. You can classify according to the handles. Like these are the finger movement baskets. The fingers are moving, the thumb is fixed. Others are the thumb moving baskets. There are two different type of handles are available. One is opens your basket handle from the Boston. That has a specific use, and we'll discuss it later. And this is a simple Cook sliding handle. So the baskets are basically divided into two parts. One is a front action baskets, and second is a side action baskets. The front action baskets, which are opens like a tri-prong forceps. So like a engaged basket, it is like a tri-prong forceps. It's the main purpose of front action basket or this type of basket is to catch the stone and release the stone. It catches easily and releases easily. It can be used only when the stone is visible, and it is based for the relocation of the stones. When you want to relocate from lower calyx to upper calyx, the front baskets are very important, and there are less chances of entanglement. Side action baskets are open sideways. You require sweeping movement. You require to engage the basket, let it lie down, and from the side the stone is grasped and then the stone is removed. It is based for the removal of the stones. Advantage of side action basket is it catches a very small fragments. So it is very easier for a small fragments to be retrieved from, especially for the lower calyxal stones, lower calyx stones. So these are the side action baskets. This is a Segura T-place. This is a zero tip basket from Boston, and this is the N circle. You can see that all are the T-place baskets, and the stone enters from the side. This is zero tip basket from the Boston Scientific. It is a walnut shape. The cage is of walnut shape. It has a two size available, 1.9 and 2.4 size. Usually in flexible ureteroscopy, 120 centimeter size is used, and it has a 12 mm opening diameter. So when the basket opens, the total diameter of this basket is 12 millimeter. So you cannot grasp a stone more than 10 millimeter at any point of time. You can see the Cook basket N circle is in action. Now you can see there is a calyxal stone, and we want to remove the stone. We advance the basket, slip it, and thus engage the stone from the side and then remove it. The Cook N circle is available into two sizes. One is 1.5 French and another is a 2.2 French diameter. There is a difference between two. There are one is a 10 millimeter basket diameter and another is a 20 millimeter basket diameter. 115 centimeter is its working length. The N circle has a three designs. One is T-place, another comes with a delta wire technology, but it is a 2.4, and a third is an helical designs. So you can see that the delta wires are minimum is a 2.4 French diameter, whereas the T-place other N circles comes in a 1.5 French. So the routinely used size is 1.5 and 2.2 for N circle. Now, Dr. Manoj Monga et al. Have done a detailed comparative study of 13 type of baskets. They studied the linearity of opening and the length at which the target basket diameter of 5 millimeter was achieved. What is a linear opening diameter? You can see that a N circle is opening. Now, when the N circle is opening, the diameter and the width have a linear correlation. So when the wire is advanced, when the basket is advanced, it opens linearly and it's closed linearly. So this is an advantage. So in their study, what they have studied is that the Cook N circle is the only basket which has a linear opening dynamics rather than all other baskets opens in an exponential fashion. What means by exponential fashion is you require a significant amount of time before the basket opens, and then it opens in exponential fashion, not in a linear fashion like the N circle. helical and flat basket follows the same. All the flat wire baskets has the same technology of exponential opening dynamics. So for opening dynamics, NCircle is the best basket according to this study. Second thing is the basket extrusion required to reach the 5 mm size. You can see the NCircle again tops in this. NCircle has a minimum diameter or a width extrusion which reach the 5 mm basket. So the small opening and small closing is the advantage of NCircle. There are two different type of the cage. You can see this is the cage. This is a walnut shaped cage and this is a teardrop shaped cage. There is a difference between these two. This is a zero tip from Boston and this is an NCircle from the Cook. Now the basket cage design also makes a difference. In this study in Journal of Endourology, Blue studies the basket comparison. They said that the teardrop shaped baskets has a more linear opening dynamics compared to the other baskets which are not opening into the linearly. Now we'll talk about the front action basket. There are three front action basket or a tri-prong like baskets, which are one is from Engage, Cook, GPO is from Bioret, India, and the Dakota from the Boston. All three has some specific designs which makes its use specifically for some uses. Like this in Engage basket, you can see the Engage basket has a two diameter available, 1.7 French and 2.2 French. It has a two diameter available, that is 8 mm and 11 mm. So when the Engage basket 8 mm Engage basket opens, the basket diameter is 8 mm, or when there is a diameter opens 11 mm, you can see that it's open to 11 mm. The advantage of Engage basket is it's hold like a basket and release like a tri-prong grasper. It is very useful for engaging, repositioning, or release of or extraction of the ureteric or renal calculi. I am very fond of this Engage baskets because most of the time I am using tri-prong forceps. I used to this action of tri-prong forceps. Now you see that how successfully the stone is relocated from the lower calyx to upper calyx. There is a stone in the lower calyx. It was a grasped by tri-prong Engage basket. Now it has been shifted to in upper calyx, and now just by releasing action, the stone is released. So it catches easily and releases easily. You can see this is a stone successful revival. There is a one stone engaged to a papilla. The stone is grasped by the basket and it is removed through the sheath. So the whole stone is totally removed by a single action. In this video, you can see that the stone is not fully visible. The stone is not fully visible. Still, an Engage basket can be deployed in this stone. It can use to retrieve the segment that is hidden, and then stone can be relocated. The advantage of Engage like or a front action basket is this, that it can be used even when there is stone is not visible. Sometimes what has happened is that like NCircle baskets or a T-place basket, is very difficult to deploy that type of baskets for removal of these stones.
But you can see Parimal, sorry to interrupt, this even though they say 1.9 French, it is looks little thick and water flow will decrease with this when compared to NCircle. What I have personal feeling, it is a very good basket. Entire my shift I have shifted to this basket, but the only problem is it goes with a little more resistance than NCircle.
Yes, NCircle has a minimum diameter of 1.5 French compared to a 1.9 French of Engage basket. So there is a difference in diameter, and that makes a water flow significantly difference between two baskets. So in difficult situations when you want a thinner baskets, you can use an NCircle basket. You can see that small stones also can be retrieved without damaging to the papilla by this Engage baskets. So one of the trick for using this type of basket is don't try to grasp multiple stone at a time. You can see this in video. I am trying to grasp multiple stones and I am losing all the stones because the stones doesn't grasp hold the stone, so the fragments get away from the grip. Another trick of using the basket is do not allow basket to go away from the ureteroscope tip. So whenever you leave a significant gap between a stone and a basket and the tip of the flexible ureteroscope, the mucosa of the ureter collapses around that part, and that causes stucking of basket. So every time whenever you are retrieving the stone from the ureter, do not allow the stone to go far beyond your vision. It has to be near to your vision, and you can retrieve all the stones with the basket. In this video, you can see that the stone is about to relocate it. The stone is grasped by the engage, but as soon as there is a catch, or the stone is not catch well, the stone will slip out of this. So whenever you want to grasp the stone, you should grasp in a proper grip before shifting or relocating it, because sometimes it slip into a difficult case and then it is very difficult to retrieve.
But at the same time, this slippage is very useful also in conditions where it doesn't get trapped. N-circle can get trapped and be difficult, and you have to do PCNL. But this
Yes.
end opening basket and catching basket, they are like tri-prong, loose tri-prong. If they are relieved also, sometimes good.
Yes.
Large stones. What do you say?
Yes, sir. It is very useful. It is actually very useful when it doesn't get stuck. Because
Yes.
in a large circle, if the stone get stuck into the basket, there is no way out.
Yes.
How to retrieve stone. In that case, it is very difficult. Either you have to cut with the laser, or you have to dismantle the baskets. Another type of this basket is Dakota. Dakota basket is a from Boston Scientific. It is a 1.9 French basket with 120 centimeter size, and it has a 11 millimeter and 8 and 11 millimeter size. It is designed to engage and reposition like the engage baskets. You can see the
engage and Dakota are almost same.
Yes, engage and Dakota are the same from the first action. The Dakota has a two action. One action is just to front movement and back movement. You can see in this video, the first movement is just like a tri-prong force. But what happens is the Dakota has a second opens your basket. What we discussed about in the handle, this is a second handle. First handle is this, and this is second handle. The second handles what do is they open like a flower. You can see in this video, like it is opening now.
So chances of gripping stone will increase.
Yes, if you are chances of gripping and releasing, chances of getting entangled into the baskets are very less with the Dakota. Like this, you can see it's opening like a horizontal flower.
Yeah.
So the main mechanism of Dakota is this, that it extends beyond the same basket opens to 15 millimeters. So it releases the basket stone very well compared to the engage. You can see the large stone is grasped by a Dakota basket. Now it is open, it is removed from the calyx, and now it is repositioned. Now you can see the Dakota in action. The second part of Dakota, the opens your handle that is used, it opens the basket more and the stone is released. This is a very large hole, the large stone. It cannot be this type of stones is very difficult to use with the engage basket. So the Dakota scores some more points over the engage basket. Only thing is the Dakota is very costly and it's slightly delicate than that engage basket. Another basket is an Optiflex basket. You can see this is the smallest available basket in the market. It's a 1.3 French. So it does not impair the water flow. So in a small cavities or where the small scopes are used, the Optiflex from Boston is a 4-wire basket and it's 1.3 French. It's the smallest available basket in the market. Second advantage of it has a very distinct cage design. The same basket can open to 6 millimeter, 7 millimeter, 9 millimeter, or 11 millimeter. So the same basket has a different and for all these 6, 7, 9 or 11 millimeter, the shape is different and it is maintained. So if you open 11 millimeter, it is teardrop. It is even 9 millimeter, it's a round like a N circle. Second advantage of Optiflex is it's a rolling thumb wheel design. So the precision of opening the basket is more. Then comes is the NCompass basket. NCompass is the baskets which has a net-like things in the end. So it is used for a multiple stone retrieval from at the end of the procedure. It has an excellent memory because it is made up of a nitrile wires and it is a knitted nitrile wires. You can see that Dr. Said bin Hamri is using a NCompass very effectively. You can see how the basket is used. The stones are flying and then the basket catches the multiple stones. This is a unique design of NCompass. At the end, there is a net-like effect and it produces significant stone retrieval at a time. You can see the multiple stones are retrieval in a single attempt. If your ureter is capacious and your access is in place, this can be useful to do the procedure very fast. For a small fragments, it is very useful to do like this also.
I also really appreciate because dust in the present world is not really dust. When you go close with scope at the end, especially popcorn, you will have this type of pieces. If you really want to remove, this is the best basket.
Yes.
There is no other way. There is no even N-circle. Dakota cannot hold such small and it takes time and they slip away because lack of the grip on the small stone. They are very good basket, N-circle and Dakota, but NCompass is particularly useful for less than 2 mm. At a time, 4 or 5 stones can be removed.
If there are multiple fragments.
Yeah. And if you spend some time, entire calyx can be emptied and almost like suction, you can give 100% results on this part. This is for small volume stones. It is very important. Patient will be very happy.
Yes. Even surgeon is very happy because they are not worried about second stage or anything.
Yeah, second stage, no need. Right. I used a long time this basket and still I like it.
Okay.
NCompass.
Yes. Now it comes the Escape basket. Escape is from Boston. The Escape is actually a 4-wire, but it works like a 2-wire. So ultimately, if it is a 11 millimeter cage, it looks like a 4-wire basket. But at the end, only there are 2 baskets, 2 wires. The 2 wires are extended from the 2 wires only. So there is a significant gap between these 2 areas. So Escape basket is used when you want to use a laser besides this basket. 1.95 French baskets, and you can graft the stone and lace it with this because
so
the chances of
the 200 micron fiber goes by the side of the flexible scope when you use less than 2 French basket, isn't it?
Yes,
so,
sir.
Less than 2 French.
Less than 2 French.
Is that in deep flexion in inferior calyx, the focusing of the laser may not be easy. If it is already relocated to the upper calyx, it's fair enough. What do you say? Is the basket and the laser fiber both are put into flexible scope? Do you think that they can be bent easily in the lower calyx?
No, it's actually with the laser fiber and baskets both in the channel. It is very difficult.
Very difficult. And don't be too enthusiastic to do large stone like this. If it is a short and make 2 pieces and then come out for a short period of 2 minutes, 3 minutes, okay. Otherwise, a big stone you can't hold and do inside because your movements will be restricted in this.
But what happens is sometimes a very large hydronephrotic hydrocalyx is there, and the one stone is moving around, and you are not able to focus with the laser. Not able to. In that cases, you can use this basket Escape, hold the stones and lace in between the laser fibers. Another is a Gemini, is a multiple helical baskets which are not very routinely used nowadays. Another things I need to discuss is about the anti-retropulsion devices, like anti-stone migration devices. It is like an engage or a stone stop or a stone cone where the baskets goes beyond the ureter, beyond the stones, and then it's open like an umbrella. So the stone fragments does not retropulse to the kidney or a difficult calyces, which were I am not very fond of this type of retropulsion devices. But sometimes it can be useful. Like this is a stone cone where the stone cone is when deployed, it is a straight wire. Once the sheath is removed, it curls and doesn't allow stone to migrate up. Now I'm going to discuss about how to deal with the stuck papilla. You can see a stuck basket. You can see that the stone is fixed into a T-place basket. It is not coming out. The surgeon is not able to retrieve the stone into the ureter. It is not able to drop the stone. The stone is stuck. The things which can be done in this case is to push the basket against the calyceal wall. So once you push against the calyceal wall, the shape will deform, and there are chances that stone may slip from that. This is the first trick you do it with this. If it is not possible, and if you are using a less than 2 French diameter basket, you can pass a laser fiber beside this and lace the stone. If it is not possible with this, you can remove the handle, you can cut the handle, remove the ureteroscope from that, go beside the scope up to the calyx, break the stone with the fragments, and then you have to sacrifice the basket in that case. Or you may lace, if you are able to pass the laser fiber, you may lace the wire. You can cut the wire with the laser. The holmium laser or a thulium fiber laser can cut the nitinol wire, and you can free the stone in that cases. But on all these cases, your basket should be less than 2 French diameter to pass through the ureteroscope. You can see that the diameter difference, a 2.2 French diameter will not allow the laser fiber to go from the B-side. So if it is using the small basket, there are the space around the basket that the laser fiber can go in. You can see again the difficult situation. The stone is in the ureter, the basket is stuck, stone is not coming out. The surgeon has introduced a laser fiber. A surgeon has introduced a laser fiber and he is lasing the stone, and then basket gets freeze and the stone fragments can be removed. These are the difficult nightmare situations. If you are, it is mandatory to gauge the fragment size by your own experience. Do not try to grasp a large stone fragment and try to free from the ureter, because the most of the chances of ureteric avulsions at the UPJ level occurs because you have a large fragment stuck into the basket and you try to remove that fragment. Be gentle. If you are stuck, try to push the stone up rather than stone coming down. Or a difficult situation can be dealt by technique like laser fragmentation or a laser cutting of the baskets. Thank you.
Excellent talk. We'll have some discussion because you finished in time. The total duration is 30 minutes only. So now, with your permission, I will stop sharing. Now, the Twitter logo has changed, I think.
Yes, it's X.
It's no more the bird, Twitter. So, if the basket entraps in the inferior calyx like encircle, what are the options? First, you'll cut it. For example, in Cook and standard companies, no conflicts of interest, you cannot reopen at the end. Whereas in Indian companies like Biorad, you can open. If you open and remove the outer sheath, you will have a lot of space. Central nitinol is a very small thing, maybe 1.5 French. Outer one milake, it will become 1.9 or 2.2. So did you have any experience where you passed a laser fiber and meddled the difficult situation? Like the way you saw in ureter, I'm asking in the narrow infundibulum.
Once I have this situation that I have grasped up the stone with the basket and it was not coming out. Basket was not coming out. I was not able to go inside. What I did was I cut the basket at the end.
Yes.
So I have to sacrifice the basket.
First you have to sacrifice 7,000 to 10,000 rupees.
Yes. Then sacrifice the tip of the basket, remove the scope entirely from the ureter.
Correct.
Again, grasp the basket and go beside the basket and then fragmented the stones and then retrieve. It has happened once only.
When I was doing that, the 4 fringes have broken and the tip has gone into the calyx, and the rest of the 4 broken one has come out. So if you, I have 2 questions here. If you have very fine, thin material like laser fiber broken in the calyx and basket broken tip, which basket is good for taking them out?
I think engage will be better in that case.
Yeah.
And the trick here is not to grasp that glass fiber or the broken part of the basket only. You can have a stone and the basket both together. Some small stone fragments and the basket both together. In that cases, you will retrieve the yes.
There is one more suggestion is that put 1 ml of blood clot, and along with the blood clot you remove it.
Okay.
In that case, coagulum stone removal type, it will be center of the clot and it will not go gently. Clot you will remove. At the end, you search in the clot, it will be there. So this is also a good idea.
This is a nice trick.
Nice idea. Second thing I wanted to ask is, what is your favorite basket in routine practice? No conflicts of interest. See, this forum is unofficial. We are discussing for the benefit of the juniors. They watch mainly for that. We tell them what if you and me are using something. So we have put some mind. I use NCircle, I use Engage, I use NCompass. Now Dakota. So now total shift has come to Dakota and NCircle. What is your opinion?
Sir, the things is the basket is handled by most of the times by our assistants. So you require your assistant to be familiar with the one type of basket. So what I have done is I always only use Engage basket. Engage basket. Very rarely Dakota basket.
Do you think that when the basket is used by the assistant, surgeon has also role where he has to keep a little flexed, extended, rotated, so that his role can be decreased, assistant role can be decreased by keeping in the center of the stone or side of the stone properly, correct?
Yes, it's actually the surgeon which focuses the stone. The basket has to the assistant has to just close the knob, that's all.
You should know opening and closing slowly. Suddenly the youngsters who doesn't know, they open widely and unnecessarily you will cause stone go here and there. Then one important question I wanted to ask, when there is a long calyx, when you have a deep side, the paracalycial region space, all the small stones will go and stuck there. You understand my point?
Yes.
The papilla will be projected, not calyx. Papilla is projected deeply into the calyx. Groove between papilla and the calyx is so deep, you cannot go with flexible scope into that groove. That is very, very irritating. Stones will be seen in front of you. Basket also does not have space. So usually we wash, it will come out. But if they stick after some time, for 5 minutes, if you are spending some time, they will stick. All 4 will be nicely stick on the mucosa. So what will you do?
So in that case, what we can do is we can use an Engage basket. Just open a little bit. Try to grasp the small fragments. Or the trick you have shown is that you can use a blood clot in that cases. Or I may use a suction. I 10 cc syringe. I just suck from that area. So it's a very close calyx. 1 or 2 ml will suck the fragments to the, and there's maintaining the suction. I will come out to the pelvis so that the stones just flow out.
Whenever the stones are stuck in slight coagulum, mild, when you are exchanging everything, suddenly they stuck with the blood and they don't move. Pop dusting effect will go. Then high frequency, if you spend some time with the water flash, they will move again and come to your basket side. I use laser because laser tip is the narrowest among all the accessories. 150 micron fiber is the narrowest among all the accessories which you use through a flexible scope to reach any part. So we go and touch the stone here and there, and gentle vibration at high frequency it will release. Once it comes out of the, usually they fall by, when we used to, in the beginning, we used to do relook for all large stones. Surprisingly, if you do powder, nothing will be there after 15 days. Nothing will be there. Especially if we put in the upper calyx, really, really good calyx. That's why RIRS is surviving. That's why some people are arguing his suction is necessary. suction will not give chance for whether it is there or not, whether to relook or not. It will spot clearance.
Yes.
Clearance. Okay. Now, do you have any idea where the 150 micron fiber have you used in the RIRS? 150 micron fiber. Are you using thulium fiber laser?
Yeah, I am using PFL and holmium.
150 micron fiber have you used?
No, sir, I did not get it.
It is available on request. If you use that, all baskets go very freely. Dual action will be very good in the inferior calyx also, especially with P7 and Flex X2. You know, P7 and Flex X2 are definitely slightly more flexible than digital scopes.
Yes, sir.
Agree,
specifically the distal part.
Distal part. Distal part is very 5 mm like that, whereas it is 3 mm. So still Flex X2 sometimes in very difficult cases, inferior calyx, it will try to take 10% edge will be there, but they are very rare. Now coming to the baskets location, how they come out. Laser fiber comes out at 3 o'clock and 9 o'clock. Do you think that baskets location coming out is also has some role?
Yeah, I think that it will be, we can see the difference when you are using a 2 o'clock or 11 o'clock pass from the BioRed. I'm using the both 2 o'clock and 5. Sometimes it happens that by channel, you want that particular position that the basket come out from that area. In the right lower calyx calculus, if there is a right lower calyxal calculus, you want the basket to come out at a 2 o'clock rather than a 11 o'clock position. It's a vice versa sometimes.
That's good. See, the same rule applies. 99% of the times you don't need it, but when the stone is stuck in one area where the scope cannot move, like in diverticulum, this type of basket can go enter, or laser fiber can go enter and do it. But those are a small percentage. That's why necessary recommendation of both scopes in initial stages is not required for the juniors. One scope will do 3 or 9. Even today, that particular amount of case is rare. Out of 101, probably. Krishnamurthy is asking, who is a colleague of me in our state, what are the Indian baskets which are durable and which work well?
Sir, one Indian basket I have used is a GPO.
Yeah,
GPO is GPO.
GPO.
Yeah, it's a same like a Engage basket. It is from it is from BioRed mostly.
So what is the cost of baskets? Is 7,000 to 10,000 rupees and sometimes 11,000 also, 12,000 also with Cook and Boston Scientific.
Yes.
Indian baskets are, I think, 3,000-4,000.
I don't think so, sir. It's around about
1,500, 1,800.
Yes. It has to be the problem with the basket is you have to have a kink resistance proper native baskets with the proper seat.
I feel memory is gone in Indian baskets very early. The moment you use fourth time, it won't curl in the lumen very beautifully. It will have a fixed stay. You have to listen to the basket. Whereas these baskets are very thin and they really go here and there. The flexibility as well as memory, what you said in the first slide is very good. The
shape memory is very important.
Memory, shape and memory are very important.
Yes.
That's where,
because what is happening is most of the time basket is inside the seat. So whenever the basket has to achieve that shape, whatever you want, walnut or a teardrop or whatever you can see that the end circle, what I have shown in that study by Dr. Manoj Monga, that there is a linear opening of baskets.
Yeah.
That is very important. What happens is you
linear
want
opening. That is a good point which I did not know. I learned today. In linear opening, 2 centimeter basket is better. That's why, because you can, if you take 2 centimeter width basket, you can use as 1 centimeter. You can use as 2 centimeter. Yes. There is no point buying 1 centimeter, because when you require to open in a calyx, if it is not opening, you can open widely. That too linearly. Yes. It will slip out of the basket. So end circle somebody is buying, buy 2.2 French or 1.9 French, the tipless 2 centimeter width opening is excellent, and you can use its little. That linear point is very, very important. What about the water flow when you use a 2.2 French basket will be almost a drop, and vision will be very less, especially in situations where some amount of blood is there. What will you do in such situations? Generally, an RIRS is a common situation where if you come out and go, like in TURP or enucleation, you will have some capillary bleeding because of the pressure drop. This is the point where I am also feeling in suction. If you intermittently high flow and suction, especially with pump, it causes capillary bleeding by the time it collapses, like a retention bladder. So how do you address? Even though it is not basket, I'm asking you generally, when reloading, when time taken is taken for the action in the flexible scope, you will have some amount of the bleeding from capillaries, which causes vision loss. How do you address?
So what is happening? There is a fixed channel of 3.6 French, and now your basket is 2.2 French basket is so there is a very less case around. So even in that case, if you actively push, even in that case, that the fluid will not harm. It will not raise the intrarenal pressure.
Yes.
So in this difficult situation, it is always advisable to use an active irrigation, and then that active irrigation will distend the calyx. So the once the distension is there, your flow is maintained, and you can reach. So whenever you are using a basket or 2.2 French basket, there is no harm in using active pressure.
Lot of water flow will be decreased. A short period of resistance for high pressure flow, use it and then finish the job instead of struggling. That is a valid point. The pressure will not rise.
And second point,
yes.
Second point was you were about discussing about the suction. What is happening is by any intermittent pressure irrigations will increases the pressure, distend the pelvic elastic system, and there is sudden collapse.
Yes.
So this collapsing and opening will cause mucosal bleeding.
Yeah.
So I am against active irrigation for a suction. Suction has to be done by a small gentle suction only. There is no active irrigation is required. We have learned a very hard way to a gravity irrigation, and now we don't want to go to reverse.
Yeah, in that case, this is better or access sheet suction is better. Your point is taken. If you want to go slow flow, happily like in TURP Gharia system, just drop by drop you go, drop by drop you suck. With that, small particles will be coming out. In that case, throw the access sheet suction is better. I feel
it is suction access sheet or a bendable access sheet or a non-bendable access sheet. If your scope is into pelvic elastic system, there is a continuous flow is maintained. So your vision will be maintained for most of the time. So it is always
that has a lot of meaning. That has a lot of meaning. My heart says that will stay there more than this. Two reasons. This is a lumen which is very thin, and whereas access sheath lumen with compared to the range of the diameter is bigger. And if at all any fragments get stuck in the lumen of the flexible scope versus lumen of the access sheath, it is better to accept lumen of the access sheath, because in the lumen, if it is struck, entire unit can be taken out. Yes. Don't do anything. If it is scope is not coming out, take out the entire unit. But if the fragment gets stuck in the scope, they say you use brush. Even if you use brush, sometimes fragments won't dislodge and it damages the system. Yes. Scope gets damaged. So in future, there will be a debate between this versus ampla sheath suction. There will be a big debate, I'm telling you. This advantage is you can use without access sheath. People who doesn't use access sheath argue that happily I go with scope, happily I will suck. But you cannot go happily. Without access sheath, happiness is less. That is my opinion. In a post-tented ureter, there's no problem. But some people are good in that work of passing the flexible scope without access sheath. But manipulation, what do you say? The manipulation of flexible scope, especially in children, it is very difficult without access sheath. In infants, my God, it is difficult. Penis will be very small. You will not have any resistance to move around. With the access sheath is not used. You need some extra skill in the wrist to do that. What do you say?
Yes, sir. Without access sheath, there are multiple gripping points like submeatus, multiple bulbar urethra, high bladder neck, lower ureteric. So what happens is your torque is not transmitted at the tip. The scope is twisting.
Yes.
Because because your scope is in the upper calyx or in the lower calyx. Now you are stuck. Now you want to move the stones. There are multiple gripping points, so that will be a twisting movements at multiple
They are
points.
all opposite forces to you.
Yes.
Bladder neck, high bladder neck, penis, everything are opposite forces.
So its excess seat is going to stay.
Axis is
What is the problem with the Indian scenario is that we want to do most of the cases with the primary RIRSs. So the excess seat doesn't go. But because in a country outside India, when there is it is very clearly said that all the patients are pre-stented for RIRS. Even non-pre-stented patient has a very good caliber ureter, and there is no need of things at that places.
As of now in the world, now we are interacting with world easily with Twitter, Facebook. We feel that 90% of the world is using access sheet, especially senior surgeons in India and across are using access sheet. Like Oliver Traxler, sir, I think uses access sheet in most of the cases. The Nepal Anil Shrestha uses, Kandar Parikh sir uses access sheet. I also use, you also use. So access sheet is going to stay, especially if you have more than 1.5 centimeter stone. You have good irrigation, outflow will be good. You will be happy with vision, and entire surgery goes smoothly. Probably, as you said, one stenting, don't take your ego into issue. Put it, don't charge. Let it come after 15 days, and then a nice job you do it. If at all you don't want to stent, don't stent at the second setting. No problem. But first setting, when the tight ureter is there, don't risk. What do you say?
Yes, sir.
Yeah.
If there is any difficulty in passing a ureteroscope, just pre-stent and then do it after 15 days. All patients are explained pre-operatively that if you want to have an RIRS only and you don't want PERC, then we'll stent and come back again after this. If you do not want
your presentation,
just do it PERC and remove it.
Yes, in all your presentations, you have told various indications, but you have not spoken about the relocation, which basket is better, especially Arshu kidney, especially ectopic kidney, especially these things. So
for all relocations, the front action baskets like Engage or Dakota baskets are good. Dakota is the best because it doesn't entangle the stones. It can open widely, just like a flower, and releases the stone. So it is more about, not about the grasping, but it is about releasing.
Yeah.
So in Dakota is the best for relocation of these type of stones.
Yes.
If you do not have a Dakota, you can always do a Engage, and it is also good.
Engage and Dakota, as you said, more or less same, except the last part of the this thing. Now, I think we have discussed enough. I don't have any questions coming because spontaneously I was asking. I think this YouTube link will be very useful for at least another 2 years. After that, new things may come. These 2 years, it will be very, very useful. I don't think technology will change that fast. Only thing, my question to you, last question, concluding question, whether the flexible scope size decreased to less than 6 French with channel same size will do the job for the future, so that people can pass it like 4 by 6.5 ureteroscope. See, 4 by 6.5 ureteroscope became crazy for juniors also. 6 by 7.5 is doing very well, but future, if the stone size is less in ureter, 4 by 6.5 will replace the 6 by 7.5. Similarly, all ureteroscopes are more than 7 French. 6 French ureteroscope with 3.4 lumen. What is the take on you? Like this,
if scientists or the research and development can come to that stage, it will revolutionize the management of the stones, because when that case is
150 micron fiber, laser fiber, good lasers, future these hybrid lasers, and 6 French flexible ureteroscope. In that case, access sheath also concept may decrease. Then nice utilization up to 1.52 centimeter stone for RIRS. Then it will become choice of the treatment. At least ESWL will be removed from the AU and EAU and Indian guidelines. That because all the discussion is ureteric damage. Yes, one should not do it, but yes, it will not happen if you are cautious. In the senior's hand, it happens less. juniors should be cautious whenever you are using all these baskets, as you said, in the upper ureter. You hug with a stone and come out slowly. Where you cannot come out, you go back immediately.
Yes.
If you are departed with stone with a thin strim, then you are in soup. Neither your scope goes back, neither your stone comes to you. So that is a very good slide you have shown. In that case, working with the laser fiber is really tricky. And sometimes people have opened in such situation, chup chop, open ureterotomy and then taken out the stone. So that level problems are there in urology. Thank you very much for such a nice talk. Wonderful talk. Was what I expected. You have given 100%.
Thank you, sir. Thank you, sir. Thank you.
Thank you very much. 1 second. We ended.